QSEN Learning Module, Using Simulation in Leadership Courses, Providing a Means for Application of Core Concepts. This is a three-part module. Part 1 will provide a brief review of literature supporting use of simulation with leadership content and scenario content selection and criteria. Part 2 will focus on the process of simulation development. Part 3 will discuss evaluation of the experience from students and faculty. Now a look at the module objectives. Following completion of this module, participants will be able to 1. Discuss the role of leadership concepts applied in simulation exercises to promote quality and safety in the healthcare environment. Identify the steps necessary for the creation of a leadership simulation exercise. 3. Develop and implement a leadership simulation exercise using the tools provided in this module. The literature is replete with studies and anecdotal writings about the implementation of simulation in pre-licensure nursing education. In most instances, simulation is patient-centered in order to teach skills, reinforce skills, teach critical thinking, and as a substitute for real-life clinical experiences. According to authors Dory and Sullivan in a 2010 published article, these simulations typically serve to address the issues of safety and evidence-based practice. In contrast, there is a dearth of literature about the use of simulation to teach leadership skills in general, and even more scarcity is noted when searching for literature that addresses both leadership skills and patient safety. However, some educators have begun to supply much needed literature on the subject of simulation, safety, and leadership. Reed, Lancaster, and Musser, 2009, designed and implemented a simulation experience to assist their students in development of skills necessary to function in a beginning charge nurse role. While not a specific intent of the simulation, patient safety was addressed indirectly through attention to appropriate delegation and provision of quality care. Similarly, Simons, Wilcox, Scott, Gedden, Copley, Dedcock, and Kipley in 2010 used simulation to reinforce theory relevant to scope of practice and delegation, which also enhances patient safety. During the simulations, the authors made observations relevant to several of the QSEN competencies. The ability to delegate and supervise, which address safety, use of leadership skills, which address teamwork and collaboration, and teamwork itself, along with cultural competence, which gives attention to patient-centered care. Others, such as Kodura in a 2010 article, have used simulation to determine how simulation affects new graduate nurses' critical thinking, learning, and confidence. One of the themes that emerged from this study was fostering critical thinking and leadership skills through feedback on simulation. The nurses reported that simulation using critical care cases sharpened their leadership skills and spoke specifically to enhanced delegation skills, effective communication, and improved teamwork. Sullivan, in a summary of activities of the QSEN project, reported this finding from a study published by Smith, Cronenwet, and Sherwood in 2007. Sullivan also reported that the content area from QSEN less frequently incorporated into curriculum in the surveyed schools was that content related to leadership, teamwork, collaboration, and quality improvement. Kaplan and Ura recognize that challenges exist for incorporating leadership skills into practical experiences similar to those of clinical. However, a simulation learning exercise was developed that addressed the issues of prioritization and delegation. An evaluation of the exercise was very positive, and students felt their learning and confidence was improved in these areas. Waldner and Olson applied theory from Kolb's theory of experiential learning and Patricia Benner's novice to expert theoretical framework to examine how simulation could be used at different stages, particularly for the advanced beginner and the novice who have limited real-life experiences on which to base decisions. During initial conversations, core faculty in leadership courses discuss the unlimited possibilities of appropriate content for cases relevant to leadership. However, given the size of the class, the amount of content in the class, and limited resources, we quickly realized that some method of prioritization would need to occur. Thus, we looked towards a theoretical basis for content selection, centered around three key documents or schools of thought: the QSEN competencies, the IOM report, and the essentials of baccalaureate education. First, critical to the identification of content for the simulation was examination of the QSEN competencies. While most institutions focus on patient safety as the most common competency along with evidence-based practice, the other competencies such as teamwork, collaboration, and quality improvement are most fitting for leadership. Second, given the IOM report, it was decided that it would be appropriate to consider its findings. Leadership skills in beginning nurses are crucial if medical errors are to be reduced and quality of care enhanced. Third, the simulations needed to be in tune with two key essentials that were directly relevant to the leadership course: Essential 2 and Essential 6. Essential 2, basic organization and systems leadership for quality care and patient safety. Knowledge and skills in leadership, quality improvement, and patient safety are necessary to provide high-quality health care. Essential 6, interprofessional communication and collaboration for improving patient health outcomes, communication, and collaboration among healthcare professionals are critical to delivering high quality and safe patient care. The content selection process required much thought. In most instances, leadership is seen as a theory-only course, with very little opportunity for the student to recognize the practicality of the content or to view information as a skill set. Prior to meeting with the development team, two faculty members met and identified possible content from the topical outline that we felt was critical. In addition to consideration to QSEN, IOM, and the Essentials document, we considered what we believe would be most needed and relevant to the student's entry to practice. This perception of relevance was also based on informal observation and conversation with new graduates in a transition to practice program. After much contemplation, the team of faculty, all those teaching the leadership course, along with the director of the Clinical Education Resource Center and one of her assistants, met to begin the process of case development. The director for the Clinical Education Resource Center suggested that we examine cases from the ARC site and brought some to our first meeting. At the conclusion of this initial meeting, the team had selected 8 cases that would be revised and developed to to meet our needs. The team of faculty met every 2 weeks. At these meetings, we each presented our cases and engaged in discussions of the content and how to achieve the desired outcome. The discussion included attention to reality of the case, resources needed to implement the case, time required to implement the case, and general discussion about simulations. In some weeks, only a few of the cases were discussed. In others, all cases were reviewed. This process of meetings continued until the cases were considered complete. The cases selected included lateral violence medication error, the two-challenge rule, delegation, just culture, performance appraisal, leadership styles, communication, and teamwork task assistance. Rationales for these content areas were varied, but collectively they represent content that a beginning nurse would need to use on a day-to-day basis, but which students frequently have regarded as having difficulty utilizing in a real-life situation. For example, when communication breaks down with physicians, how can they approach them and make suggestions for safer care and better outcomes? In the case of delegation, the omnipresent NCLEX examination has moved towards an increase in numbers of questions relevant to delegation. The team felt that the just culture simulation was crucial to patient safety, as nurses may underreport errors or near misses due to the threat of punishment and blame. Each faculty developed 2 scenarios and accompanying facilitator tools. The development team included Darlene Baker, Carol Durham, Denise Hurst, Shilda Rogers, Joanne Williams, and Meg Zamarodi. Julie Jacobson Van served as one of our faculty facilitators in the pilot.